central venous pressure. And I think another pictures here is the lack of agreement between different metrics of congestion in patients with acute heart failure, in patients with chronic heart failure, even asymptomatic heart failure. And this signifies the complex pathophysiology of congestion and the need to use different modalities to understand the whole picture of congestion and to understand to what extent each mechanism contributes to congestion with further treatment, to further tailored treatment strategy, which is now primarily aimed to reduce extra sodium and water, but probably it can be redirected towards reduction of left atrial pressure or enhancement of vascular capacitance function. So we will see. But of course, we have a lot of new advances in the terms of assessment of congestion, but what about role of clinical assessment? Do we still need to use it in our clinical practice? And the answer is definitely yes. The clinical assessment remains central in the management of patients with heart failure, and although we have a lot of clinical signs and symptoms, and to improve their prognostic value, some of them were introduced like several using clinical composite congestion score, but the most sensitive and specific for volume overload is jugular venous distension. But at the same time, we have to think about another opposite side of volume status, like volume depletion, and to use orthostatic testing to exclude it. From clinician perspective, clinical assessment of congestion is fundamental for assessment patient profile, for interpretation of end organ dysfunction, for decision making, for assessment of prognosis of patients. But clinical congestion is also very important in terms of patients. It is the main contributor to reduced quality of life, and it is the main cause for patients to seek medical care. And we all know very well that almost 90–95% of patients admitted with heart failure and signs of congestion, but perhaps the most importantly, half of them, or 1/3, discharge with congestion. It was shown in many studies that residual congestion at discharge is associated with very high mortality and high risk of repeated readmissions with heart failure. And that's why we have another new chapter in the recent European guidelines on pre-discharge and early post-discharge follow-up for patients with heart failure. But most importantly, the congestion still conveys important prognostic information for patients with chronic heart failure as well. And here the results of post-hoc analysis of Paradigm HF, where even one sign of congestion in stable patient on optimal medical therapy was associated with 30 or 60% of increased risk of all-cause mortality and almost doubling risk of heart failure readmission. And the same pattern we see for patients with heart failure with preserved ejection fraction based on the results of TOP-CAT trial. When the higher the number of congestion signs, the higher the risk of negative outcomes. But what is also very important, that each additional increase of signs of congestion was associated with 30–60% increased risk of each outcomes. And this highlights that serial physical examination serves like a target of therapy, and reduction of clinical congestion is very crucial to improve patient outcomes. But of course, we have to understand that clinical assessment have some limitations. Symptoms are highly subjective, and some patients may not understand and may not recognize when heart failure develops or worsens. And that's definitely the question of patient education and careful history taking. Clinical assessment is a subject of inter-provider variability, but this improves with greater experience. We have some difficulties in distinguishing congestion from other not cardiac causes of symptoms and signs, and that's why we have to use like comprehensive assessment for any patients with heart failure. And clinical assessment has low sensitivity compared to other metrics, and perhaps the most important, it is the late manifestation. It is late manifestations when we consider the whole spectrum or evolution of cardiovascular disease continuum, but it is also late in terms of worsening heart failure, and we very well know that increased filling pressure, increased biomarkers, or lung fluid content measured by lung ultrasound or impedance-based technique precede by manifestation of clinical congestion by weeks and days. And yes, for many years, the heart failure care had been reactive, primarily driven by clinical assessment, but perhaps using this novel technology, which allows us to early detect subclinical congestion, and the more importantly, to use this information for early actions to prevent congestion in patients with heart failure or prevent even development of heart failure using optimal medical therapy, well-balanced diuretic strategy, and the treatment of comorbidities and risk factors, perhaps we can reduce the burden of heart failure. And of course, future studies are needed to better understand the clinical and prognostic role of congestion in heart failure. Many thanks for your attention, and I'm really thankful for this opportunity to be here today.
Thank you very much, Angela. It was a really nice talk. Let's move to the next talk. It was ultrasound imaging of congestion heart failure. It's a very important thing. And may I introduce Pierpaolo Pilipori, a clinical cardiologist currently working as a senior clinical research fellow in the Robertson Center of Statistics at the University of Glasgow, United Kingdom.
Thank you.
Yes, please.
Okay. Thank you very much, and good morning, everyone. Sorry for the technical issues. And my name is Pier Paolo Belligori, and I'm a cardiologist. I work at the University of Glasgow in the UK, and I'm very honored to be with all of you today. These are my conflicts of interest. So, as you heard from Angela, congestion is a cardinal clinical feature of heart failure and is responsible for signs and symptoms of heart failure. Is highly prevalent either in inpatients and outpatients, but more importantly, it's also associated with the very bad outcome you can see on the left, data from the UK heart failure audit in acute heart failure patients, and on the right in people with chronic disease, so the ambulatory patients with heart failure. As you also heard before, there are problems with signs and symptoms of heart failure. So they are very late manifestation of disease. Patients might avoid them just by adopting a sedentary lifestyle. So if they spend their time just watching TV all day, they will be entirely asymptomatic. They are subjective. They have low specificity, can be found in many conditions such as COPD or obesity, or they may be due to medications that are frequently used in people with, for instance, hypertension or diabetes. And more importantly, as also Angela mentioned before, cardiac dysfunction and congestion might be silent for years. So basically, if you wait until signs and symptoms develop in a patient and they are so severe that they require hospitalization, well, probably you may miss many patients because they might die during this journey. And this is actually one of the things why we had not only one new definition of heart failure, but actually we had two. This was proposed by John Cleland and other colleagues that really defines heart failure as the combination of cardiac dysfunction with congestion. And when we talk about congestion, congestion refers to NT-proBNP or dilated left atria, but regardless of the symptoms, again, because if you wait until symptoms develop, this might be too late. So this expands the other definition and probably anticipates diagnosis earlier. So the left atrium is an early marker of congestion. As why is that? Is if you look, there is an abundance of manuscript and research done in the general population where many colleagues shown that increasing left atrial size and dysfunctional left atrium are associated with high NT-proBNP levels, but not only, but also with an increased risk of events in both men and women. And with chronically elevated high filling pressure, then again, as Angela said, the problem progresses further backwards, so it might cause elevation in venous pressure and also extravascular fluids. And probably this will be the focus of my next talk, how to identify these things by ultrasound. So you have already seen this slide. This slide was done in patients in an ambulatory setting, in people who had no signs, no clinical signs of congestion at all. So they were entirely dry. They had little symptoms. So they are those sort of patients that you think, oh, this person is going to do very, very well. But actually, in these people, we identified that 50% of them had at least one sign of congestion by ultrasound, either a dilated inferior vena cava or a distended jugular vein or a high number of B lines. And in those 5% of people who had all the three signs simultaneously, you can see that the median NT-proBNP was around 4,000. So these patients who have all these signs of congestion are likely to do very badly if you don't do something to fix that condition. The inferior vena cava is a marker of right atrial pressure and is diagnostic in people who are admitted with dyspnea because when it's stiff, it identifies those more likely to have heart failure. Obviously, you might track the response to treatments, and if the IVC decreases during the from admission to discharge, that's a good sign. But when it persists as dilated and is still at discharge, you identify these people with a very stiff IVC. This predicts poor outcome, and you need to pay a lot of attention to these patients. In ambulatory setting, so in your clinic, a dilated IVC, we found that it correlates with increasing age, higher NT-proBNP, more dilated left atrium, and higher pulmonary artery pressure. And you can see here that it performs as good as NT-proBNP in red in predicting the risk of future events. You might also look at the collapse of the IVC during inspiration, or even at the sides of the intrahepatic veins. They will provide the same information prognostically. But my issue is that in patients with heart failure, up to 10% of patients, I cannot really assess the IVC for many reasons, either because the body habitus, or in obese patients might be difficult, or many, they might not tolerate the assessment because they might have pain or whatever. So this is why we decided to develop a new method just to look at the heart from the other way around. So just by examining by ultrasound the internal jugular vein. And here I present two, let's say, a spectrum of disease. So two patients of a different spectrum. So in the left panel, you can see a person with heart failure whose NT-proBNP is very low. This person has a very small jugular vein at baseline, but when we ask them to do a Valsalva, the ratio of the vein increases for 6, 7, up to 10 times. This suggests things are very nicely controlled. In a person whose NT-proBNP is very high, as that on the right, you can see that the jugular vein is already distended at baseline. And when we ask, obviously, to do Valsalva, because of the compliance of the vessel is limited, the vessel increases by 2-3 times. And again, this is not a good sign, as you can see here from this curve in blue, because these patients are at greater risk of developing events, whilst those in whom you have managed to control congestion, they actually have a very good outcome here in green, which is as good as those which we did not identify as having heart failure. Doing JVD by ultrasound is easy, can be virtually done in everyone. When you need a bit of training, but 20-30 patients would be possibly sufficient. And you can see that it is associated more with signs of right ventricular dysfunction and with congestion, if we define congestion by elevated NT-proBNP, rather than with the dysfunctional left ventricle. Now, you can also put your probe in the lungs and assess the amount of extra vascular fluids. So a normal lung, you can see here on the left, this is how it should look at ultrasound, just dark on the screen because it's full of air. But with increasing fluids in the lungs, you might see that vertical lines arise from the pleura and move down to the screen. These are called B lines, and again are signs in patients with heart failure likely of extravascular fluids. The more severe the problem becomes, the greater the number of B lines you might be able to see, and they might occupy the entire screen, as here. Obviously, when the problem is so severe, the lung might collapse, and then you can see a collapsed lung with development of pleural effusion. Lung ultrasound are diagnostic. They might help and facilitate a diagnosis in those who present to the emergency department with dyspnea, and they may do as good as or even better than NT-proBNP, as shown by our colleagues in Italy here. And as you may expect, the greater number of B lines your patient has, the greatest is the risk in both acute heart failure patients, chronic heart failure patients at admission or at discharge. Now, I suspect that later on you are going to hear that heart failure is a cardiorenal problem. So even assessing the kidneys might give you useful information, particularly when you look at the venous system. This is a kidney. You will require a probe, an abdominal probe. Once you identify the kidney, you put your sample on the parenchymal vein. You set low velocity, and you examine the venous flow by asking the patient to hold their breath. Very simple. In normal circumstances, the venous flow here on the top, it should be continuous. But when the venous pressures increase, the kidney becomes more congested. And because the kidney is within a capsule, obviously this squeezes the parenchyma, it squeezes the veins, and obviously because also the intravenous pressure is high, when the veins have to drain blood back to the normal circulation, they find an obstacle, and the only way to win the resistance is to generate higher pressure. But to generate higher pressure, you will notice that the flow starts to become discontinuous and biphasic. So a problem starts to happen. This indicates that there is a problem there. And when the problem becomes more severe, the flow really becomes monophasic with these peaks, and then followed by an interruption of flow into the veins. And you would expect that, obviously, to find that the patient here, as you can see in red, these people are in danger. So you need to act. Obviously, the key question is whether by using ultrasound we can track congestion. Can we see changes in congestion? And this was an early study that we did around 4 or 5 years ago, where we developed a method to identify which variable actually by ultrasound could identify congestion. So we did this trial, was crossover trial, only 20 patients. We asked them to come on 2 occasions whilst they were taking their heart failure medications, or we asked them to stop their heart failure medications for only 2 days. They were obviously patients on NYHA class 1 or 2, so mild heart failure only, but by stopping diuretics and ACE inhibitors and beta blocks for only 2 days, this led to a doubling NT-proBNP. It led to a change in left atrial volume and IVC diameter by around 20%, whilst we did not observe any change in body weight, heart rate, or left ventricular ejection fraction. Again, this suggests that NT-proBNP, atrial volume, and IVC may be very sensitive to identify subtle changes in congestion. There are also trials showing that lung ultrasound might help you, again, in providing a more objective use of diuretics in people who have congestion, and this might improve, let's say, at least how people feel. We have at least 3 randomized trials so far, but more are still ongoing. And potentially treatment of congestion might actually delay heart failure. So this was a trial that was published early this year and was conducted across many centers in Europe in people who were asymptomatic, who had cardiovascular disease, such as ischemic heart disease, or risk factors like type 2 diabetes or hypertension. They had to have an elevated NT-proBNP, so under 25 to 1,000. They were in sinus rhythm. They were not taking any diuretics, so they were the asymptomatic, entirely asymptomatic, and they were randomized to spironolactone and very standard care. You can see that the use of spironolactone compared to standard care, it decreases not only NT-proBNP at 9 months, but also it managed to decrease the left atrial volume. So I'm going to conclude just by saying that congestion is a cardinal clinical feature of heart failure. We learned this in the previous presentation. But using ultrasound, you can assess congestion very objectively. You can quantify it, and you can do it simultaneously and comprehensively in multiple organs, such as the heart, but also the lungs, the kidneys, and the great veins. Next step will be to see whether the assessment of congestion by ultrasound can be used to guide therapy in people with or at risk of heart failure. Thank you very much.
Thank you very much, Pierpaola, for putting it together and how to master congestion. And I'm delighted to welcome our next speaker, Frederik Verbrugge, who is cardiologist and intensive care physician with dedicated interest in heart failure, hemodynamics, exercise physiology, and cardiorenal interaction, University Hospital Brussels, Belgium. And he will talk about urinary sodium and diuretic resistance in heart failure patients.
stop sharing and I share again. So you can. Control my slides. Okay, now it works. Okay. Yeah. I can start?
Yes, we can see your slide and we hear everything is fine. You can start your talk. Thank you very much.
Okay, I'm sorry for the hiccups in the technical problems. So I'm very grateful for the organizers to be given the opportunity to talk here about urinary sodium and diuretic resistance. So I think Angela and Pier Paolo have beautifully set the stage how important congestion is. So I will now go on and see how we can tackle it with diuretics. These are my disclosures. So when we think about kidney function, we should really realize that this is more than just serum creatinine and GFR. Very often when you ask somebody what is the kidney function of the patient, you get that as an answer. But you should realize that this is really the clearance function of the kidney, how the kidney is going to handle the toxic waste products of the body. While there's also another kidney function, and that is homeostasis, and that is arranging the volume status and the electrolytes of the body, and that is really a totally different function as the clearance function. There's also an endocrine function. The neurohumoral system is also very importantly regulated by the kidney. We will not have time to go into that, but really kidney function is more than just creatinine or GFR. And kidneys, you could consider them a really great solution to a very difficult dilemma, because the body needs to excrete a lot of the waste products, and that is the clearance function. But at the same time, it needs to keep also the things that are good, energy, nutrients, and also salt, and that is homeostasis. And the way that the kidney has developed that, we should realize that this is the product of more than 3 billion years of evolution. And the largest part of that evolution actually took place in the water and in the sea. And so when you look at the evolution from marine fish to mammals, you could see that the clearance function, the glomerulus, is quite preserved over time. But what the organism had to invest in was systems first to retain the salt from going from the sea to fresh water, and then when coming out of the water, really needing to invest to retain both the sodium and the water. And what you can see is that this has happened because of a very much evolved tubular system, and this is really the system which is in charge of homeostasis. So first, looking at clearance or GFR, you should realize that with a normal GFR of 125 milliliters per minute, you actually filter 180 liters a day. So approximately 40 times your total blood count is cleared by the kidneys every day. So this is a tremendous amount. This also indicates that the largest part of what is actually filtered by the glomerulus, it should be reabsorbed by the tubular system. When you look at the determinants of glomerular filtration rate, these are actually three. First, there's the total number of working functional nephrons. Then there are the surface and permeability characteristics of the glomerular basement membrane. And then they are the Starling forces within the glomerulus who govern the filtration. And what you should realize is that the last factors, they are all quite dynamic. They might change with changing hemodynamics. They might change with rapid fluid shifts, as is very often the case in heart failure. While the number of actually working nephrons, that is actually quite fixed and therefore also highly prognostic. And indeed, when you look in chronic heart failure, really kidney function is a very good indicator of prognosis. And when you compare this even to heart function itself, here demonstrated as ejection fraction of the left ventricle, you see that the correlation with GFR is much stronger. And this is because all these people are in stable chronic heart failure, no rapid shifts in the volume, and therefore the GFR really resembles the number of functional nephrons and the kidney reserve, if you want. But the problem in acute heart failure is a little bit different. There the problem with the kidneys is not so much the clearance function. So we don't encounter very often problems of uremia in our cardiorenal patients. No, the problem we here have is a problem of homeostasis, a problem of fluid, a problem of electrolytes. To illustrate that, I want you to think about a patient who is very close to dialysis and has a GFR of only 15 milliliters per minute. And you should realize that even with this very poor GFR, this patient still filtrates more than 20 liters a day. And with a normal sodium concentration, this would correspond to 184 grams of salt. So the problem, even with this very poor filtration, it is not the filter itself, it is the reabsorption, it is the tubular system where the problem lays in most of our patients with acute heart failure. And this is illustrated by this study that we did. And this is an acute heart failure. These were actually all cardiorenal patients. So they had a poor kidney function at baseline, high risk for renal events. And what we did was we looked at different markers for glomerular function, of course, serum creatinine, but also cystatin C and beta trace protein. And depending on how you define which marker you choose, which formula you choose, you probably have an incidence of worsening renal function of approximately one third of those patients. But when you look at the prediction of 30-day mortality, what really matters is not the change in GFR. It is actually the change in natriuresis, which is much more predictive. And this is, of course, because this reflects more the actual problem in acute heart failure. What you should also realize is that natriuresis, although it corresponds quite well to diuresis in most patients, actually the correlation between natriuresis and urine output is probably around 0.9. There might be a difference, and especially in the complex cardiorenal patient. And this is a sub-analysis from the ROSE trial. This was also a really dedicated cardiorenal trial. And what they looked at was actually the sodium balance. And they were nicely able to show that even when you have net fluid loss, if you have a positive sodium balance, your outcome is not going to be good. And actually, we should not be too surprised with that, because we know already from the big trial with tolvaptan, this is a vasopressin antagonist, which gives you pure aquaresis, dehydration, if you want, that although these improves signs like edema and lung congestion, there's actually not an impact on cardiovascular mortality or heart failure hospitalization. So it is really all about the sodium. And this brings us to this very nicely done study by the group of Testani in Yale. And they brought really the spot urine sodium into the equation and nicely showed that when you measure spot urine sodium after administration of your diuretics, you could actually calculate the total amount and predict the total amount of natriuresis. And so how do they do that? Is in the formula is, of course, the GFR. there. Then they adjust for the creatinine concentration in the urine, which is kind of a marker of how concentrated your urine is. And then they found out that with a time constant of a little bit over 3 hours, this would, when you multiply this with the sodium concentration in the urine, you could quite reliably predict the total amount of natriuresis being caused by your diuretic administration. And in this study, you could also nicely see here, you can see on the x-axis the sodium concentration. And then you can see the relation between the actually predicted sodium output and the effective sodium output, and this is the red line. The predicted one is the dotted line, and you can see that especially above a sodium output of 70 millimoles, that the formula is actually very, very reliable. In the poor urine output, there might be some deviation and some overestimation. And this is a study that we did, which very nicely showed that the key is really in the P. And when you decongest your patient, you see that the sodium and chloride concentration is dropping very rapidly, while the urea concentration goes up. And one of the best predictors of whether you actually will have good urine output or not is the sodium concentration. These were, again, very vulnerable cardiorenal patients where it might be interesting to correct the urine sodium concentration for the creatinine excreted. But in most patients, this would be approximately 1. So you could just use the urinary sodium concentration as well. And there, really, when you go below 80, 85, this is when your urine output really starts to drop. And this is, of course, mainly observational studies and physiology, but this has been incorporated in the new heart failure guidelines from the ESC, which were published in September. And although this might look like a complex algorithm, basically what it says is that you should do 3 things. So first, you should choose a loop diuretic dose, and we will come back on that in just a moment. And then you should assess diuretic and natriuretic response. For everybody, it's quite logical that when you give a vasopressor, you're looking at blood pressure. So what we here actually saying is that when you give a diuretic, you should also look at the diuretic response and maybe also the natriuresis. And then, of course, you will only influence prognosis when you adequately act upon this. So you should intensify the therapy when needed. Now, first, when choosing the loop diuretic dose in the guidelines, they say 20 to 40 milligrams furosemide IV for a naive patient, and 1 to 2 times the oral maintenance dose for a patient who is already on a loop diuretic. I will try to convince you that this is maybe not always the best way to go. So when we look at the pharmacokinetics of loop diuretics, we all know that they are threshold agents. So you need to achieve a certain dose before the effect really kicks in, and then there's a ceiling effect. So the dose response curve is really sigmoidal. And what we really know very well is that when your GFR in chronic kidney disease is depressed, then the slope is much less steeper, and so the threshold is very much increased. And so maintenance dose doubling is always a good start. I tend to disagree with this statement because imagine that lady with a GFR of 30 who is on furosemide 40 milligrams. You probably have tons of those patients in your practice. Doubling the dose would lead to 80 milligrams, and I would consider this still probably an inappropriate dose for a GFR of 30. So what I do in practice is actually dose my loop diuretics according to the GFR. So the worse the GFR, the higher the furosemide bolus that I give. Then you should realize Lasix lasts 6 hours at max. So when you use bolus, you should repeat them every 6 to 8 hours probably to have a continuous effect. You might adapt the pace of diuretic therapy to preserve the effective circulatory volume. And you should also realize that some of the edema and some of the fluid in third spaces is not really recruitable, and you might tap ascites, you might tap pleural effusion and use compression stockings when needed. So really we could simplify the whole first part of this algorithm by choosing our loop diuretic dose right and dose according to eGFR. And then basically it comes down to tracking what the effect is. And there, so you should realize that a very good diuretic response is probably a sodium concentration above 100. Below 50 is really, your natriuresis is very poor and you should act immediately. But also 50 to 70 is probably borderline and you might want to intensify treatment there. 70 to 100 is probably acceptable. Now, one thing you should realize, of course, is that patients who don't have volume overload and are euvolemic, or patients who have poor renal blood flow, maybe because they are low output, they also present with low urinary sodium. So those two things you should consider from the beginning. First, is my patient really volume overloaded? And as the previous speaker has elaborated, echo might help you there very well. And if there's poor renal blood flow and low cardiac output, you should solve that first, because the kidney can of course only excrete what it receives from the heart. And only then, when there is volume overload and you have poor urinary sodium, you might consider combination diuretic therapy. And what should you consider there? One very interesting thing in heart failure is that we know that proximal tubular sodium reabsorption is increased. And this is because when your GFR drops, actually your filtration fraction will go up. So more of the fluid that is passing through the nephron will actually, percentage-wise, be filtrated. And therefore the blood in the peritubular capillaries will be thicker and have a kind of a suction effect in the very leaky proximal tubules. And the two diuretics we have to influence it there, it's acetazolamide and SGLT2 inhibitors. And for both, we have now some preliminary evidence that they are actually quite good boosters of loop diuretic efficiency. There's the study of Kevin Daman from Groningen, which shows that when employing empagliflozin, an SGLT2 inhibitor in acute heart failure, you actually increase the urine output. And then there's our study with acetazolamide, which also shows that you increase particularly the natriuresis with acetazolamide. Probably this effect is a little bit stronger because the amount of sodium reabsorbed in the proximal tubules by the proton sodium exchanger is higher than the SGLT2 inhibitor. There's a big phase 3 study, the ADVOR study, underway, so we will probably have the results by the summer. But I want to really emphasize that these proximal diuretics, they are really smart diuretics. When you give them solely as monotherapy, you don't have much difference to placebo. But when you combine them with loop diuretics, they really work as a loop diuretic enhancer because they present more sodium to the loop of Henle. And by presenting more sodium, they also tend to decrease neurohumeral stimulation. And this probably explains why they effectively reduce the plasma volume. And this is a very interesting hypothesis why SGLT2 inhibitors really improve outcomes as well. They are a lot more, but this is very interesting because they potently decrease the plasma volume. I also want to emphasize that it is safe to add spironolactone early. This is a study we did in patients with very poor renal function, CKD at baseline. Main GFR was around 30, and we actually saw not more hyperkalemia and probably less hypokalemia. And although the Athena study didn't show an effect of spironolactone on heart clinical outcomes, it might be interesting to assess natriuresis. What we found was this in this group of patients with very poor renal function, natriuresis was actually increased with upfront spironolactone. And when doing all this and still encountering diuretic resistance, then probably the reason is hypertrophy of your distal nephron, which will adapt when giving a long time proximal diuretics by being hypertrophied and reabsorbing more. And there, the way to treat it is really with diazides. Probably it don't matter so much which diazide you use, but you should be aware of the equipotent dose. I tend to use chlorthalidone because that is the one which is available in Belgium and has a very nice long working action. So this is my final slide. We have this very nice algorithm by the guidelines, but we could really simplify this even more by choosing our loop diuretic dose right from the beginning and dose according to the GFR. Repeat every 6 to 8 hours the bolus, and then assess diuretic response. And really continue until there's no residual congestion and there is actually a low urinary sodium concentration. Improve the renal blood flow when it is low and use MRA, SGLT2 inhibitors and maybe acetazolamide at a low threshold with thiazides when resistant. Thank you for your attention.
Thank you, Frederick. It was a really nice talk. May I introduce our chair, Professor Lopetin, and he will introduce the next speaker.
Thank you, dear colleagues. Now it's my great pleasure to invite Dr. Amina Rakisheva from city of Almaty, Kazakhstan. She will talk about the optimal medical therapy in decongestion. Amina, the screen is yours.
Thank you very much. Thank you so much for a great invitation. I'm very honored to be here, to be part of this session, as well as to be part of this Congress. For me, it's a very great opportunity to meet my friends and to meet my mentors. And actually, after listening to the previous speaker, I understand that, there is not so much from my side to add, but I will try my best. And before I will talk about congestion and optimal treatment of congestion, I would like to say that there is, for me, in my opinion, very main goals. It's to relieve symptoms and signs and to prevent congestion. And when we're talking about this treatment, we have to understand that we have to talk about two very nice guidelines. One is a position paper that was published in 2019 by HFA, and it's about the use of diuretics in heart failure with congestion. And another one, it's guidelines that were published this year, the guidelines of for the diagnosis and treatment for acute and chronic heart failure. So, and as my previous speakers, told, it's very difficult sometimes to identifying congestion because of compared to gold standard, it's different parameters has their own sensitivity and specificity. I'm sorry, but when the congestion was identified, it's understandable that we have to start our decongestion strategy of treatment, but when we have to stop this treatment, that is also very crucial, but it's also not easy to identify at one point. Because if we see here, there are different parameters have their own different measures, and of course, some of them have the influenced by different reasons. For example, if we will take natriuretic peptides, they will be influenced by if the patient is obese, if the patient has a COPD or renal insufficiency, as well as other, for example, the X-ray or lung ultrasound. But of course, lung ultrasound has a very nice results recently shown even much better results. So their position paper, the authors of this position paper presented, and they suggested us their new strategy how to identify patients who are euvolemic. So it's a combination of clinical assessment together with their technical evaluation. So we understand that what is green, it's a euvolemia, and what is red is congested. And of course, when a patient is congested, we have to start to relieve symptoms and signs of congestion. And in these settings, we're talking about our diuretics. Diuretics has a very strong class of recommendation. It doesn't matter if the patient is with reduced ejection fraction, as well as if the patient is with mildly reduced ejection fraction. If they have signs or symptoms of congestion, they have to receive diuretics. This, as well as their acute heart failure, it will be initial treatment for patients with acute heart failure. But of course, as previous speaker told us about the new algorithm that was proposed and was shown as well, both this position paper as well as the new guidelines. So there is a new stepped algorithm how to use the diuretics. And I will agree with our speaker that it's very easy. Probably we can make that easier to understand and how to prescribe the diuretics, but sometimes it can be also very challenging. But this algorithm proposed us two steps actions, and one is first 24 hours, and of course it's very important because it's a very high mortality. We can see if patients admitted exactly in the first 24 hours. So we have to understand, as already was mentioned, if the patient was loop diuretic naive or not, then we have to double the dose. And I also agree that we have to start the dose doubled initially. Then the early evaluation, but it's also because of their period of action of loop diuretics. And also, it's very important that we have to evaluate their urine spot sodium and as well as urine output. And of course, if the congestion is not persistent anymore, then we have to look for another reason of congestion, because if patient is really heart failure and really congested, then congestion cannot be reduced or cannot be treated in these 6 hours. So probably we have to look for other reasons for congestion. And if we will go to the second part, we also will understand that there is we have to re-evaluate urine output every day. So if the urine output is more than 5 liters, then we have probably to reduce diuretics. But if it's not achieved, then we have to add another diuretics. But parallel to this intervention, we have always to make non-invasive measurements such as their oxygen saturation, such as heart rate and blood pressure, or even if it's very low blood pressure, then we have to make an invasively assessment of blood pressure. But as well, we have to understand that parallel to this evaluation, we have to make some interventions. The intervention will include their up-to-date guideline detected medical therapy, if it's possible at this point, because sometimes when patient admitted to the hospital, it's not so possible to administer them guideline therapy. But when it's possible, we have to initiate mineralocorticoid antagonist as early as we can do that, as well as now it's talking about SGLT2 inhibitors. It also should be initiated as early as we can. But also we have we have to strict sodium and we have to strict fluid for the patients. And here I would just like to mention why it's very important, because here the maximum dose of, for example, for loop diuretics is very high here. And that's why probably it's very important if the dose will be not 20 to 40, but to 80, as it was mentioned before. And why it's very important to prescribe every 6 to 8 hours, because of a half-life of our diuretics as well as onset of them. But when we prescribe diuretics, we have to understand that there will be a problem, and we should make some actions to solve these problems. And here it's just for you to understand that, for example, if we have a symptomatic hypertension that causing dizziness or lightheadedness, then maybe we have to reduce dose if no symptoms or signs of congestion, but if no, then we have to reconsider needs for nitrates, calcium channel blockers, and other vasodilators. If patient has a hypokalemia and hypomagnesemia, then we have to see if it's possible. We have to increase AC inhibitors or ARB or ARNI, or we also should to resync of MRI of potassium supplements, of magnesium supplements. If hyponatremia, then we have to understand, was it caused by volume depleted or it was due to volume overloaded? So then there will be two different algorithms of our actions. For example, if volume depleted, then we have to stop thiazides or switch to loop diuretics if possible, or reduce dose or stop loop diuretics if also possible. But if it is volume overloaded, then we have to restrict the fluid, consider increasing dose of loop diuretics. Then we have, if it's available, tolvaptan, for example, in my country, it's not available, or we have to consider of inotropic support. And probably if a patient due to volume overloaded, probably we have to think, but it's a final step, consider of ultrafiltration. If a patient have gout, then we have to think, but not during acute exacerbation. We have to think of allopurinol prophylaxis, but also if it's acute exacerbation, then we have to think of colchicine use. And of course, we have to avoid non-steroid agents. If a patient hypovolemic or dehydrated, then we have to assess a volume status, consider a diuretic dosage reduction. But the main thing that the previous speaker told, it was about diuretic resistance. Why? Because I think that it's very important to understand that most of the patients with heart failure who is admitting to hospital, they have diuretic resistance, and the diuretic resistance has to be solved by different actions. For example, we have to understand what is going on and what kind of mechanism of diuretic resistance for exactly these patients. We understand that if a patient has a failing heart, then probably he will have edematosis intestine, and that's why absorption of loop diuretic will be reduced. Of course, we understand that most of the diuretics are bounding with their albumin, except with their Bometanide, who is bounding with other globulins. Though if the plasma albumin is low, then of course we understand that it's unable to bind to albumin, and the concentration of diuretic will be lower. if patient has a low renal blood flow, then low GFR, there also will be a reduced filtration, and of course it will be activated of ROS system or sympathetic nervous system, and we have to understand that then it will be cost more natrium sodium reabsorption. We also have to understand if a patient has that most of the organic acids like blood urine nitrogen competitively bind to organic anion transporters. That's why they will reduce diuretic availability in the tubule. But we also have to understand that our patients, if they have this cardiorenal syndrome or just like a start of a failing heart, we have to understand that most of them will have albuminuria that will cause, albumin will bind to furosemide, and that's why it will also reduce availability for co-transporters. And we have to understand for me, it's very important things that, for example, is albumin level will be low. Of course, we can administer albumin, but we have to always remember that for patient with cirrhosis or patient with chronic kidney disease, albumin will be very nicely prescribed together with loop diuretics, for example, and we will have a very nice results. But it's not so clear how this prescription, their combined prescription of albumin together with their furosemide will be for failing heart, because we have to understand there is not so much evidence for this kind of for this treatment in patients with heart failure. And another thing that how we actually can improve the resistance of diuretics, but it also was mentioned before. It's about adding other diuretics on different parts of different parts. So for proximal tubuli or distal tubuli, for proximal we're talking about acetazolamide or SGLT2 inhibitors that shown a very nice results in patients for heart failure despite of congestion. The SGLT2 inhibitors. Then if we're talking about loop of Henle, we're talking about loop diuretics, where we also can improve their resistance if we're talking about combination of diuretics. And if we're talking about our early distal tubuli, then we're talking about thiazides. And of course, we should not forget about our MRI, where that action is for a late distal tubuli. But tolvaptans, they are working even lower than I was mentioned before. And if we're talking about prevention of congestion, we always have to understand that it's these four pillars: ACE inhibitors or RNA, beta blockers, MRA, SGLT2 inhibitors, and loop diuretics, as I told before, for fluid retention. So these four pillars will improve outcome and will reduce mortality in patients with heart failure. And they have a very strong class of recommendation. But I would also like to mention you several studies that show that probably not only SGLT2 inhibitors and not only MRI showed a very nice results in decongestion strategy. If we're talking about sacubitril valsartan, we have to understand it was published in 2019. They showed, it's a post hoc analysis of Paradigm Hf study. They showed that the combination of sacubitril valsartan together with their loop diuretics, they showed a very nice results, and it's also showed that after 1 year and even after 2 years, the need for increasing of diuretic dose was lower in an arm of sacubitril valsartan together with loop diuretics than compared to enalapril together with loop diuretics. This small study, but it's very one of important study in treatment of patients with congestion. It's a repeated heart failure study, chronic heart failure study. This study is in in use of SGLT2 inhibitors together with loop diuretics. And this study, it was double-blind study with 2-week wash period and the patient received empagliflozin 25 milligrams per day or placebo. What this study showed? This study showed that patients who received empagliflozin together with loop diuretics, they on a week 6, they received more urine volume compared to placebo. Green is placebo, red is SGLT2 empagliflozin arm. So the same was for fractional excretion of sodium. It was shown that in a group of SGLT2 inhibitors together with loop diuretics, the fractional excretion of sodium was higher compared to placebo group. And now I would like to talk about this paper that was published in 2020. This paper showed why 4 pillars will reduce and will prevent our people to be congested. First, this paper showed a comparative analysis of 3 randomized controlled trials, Emphasize, Paradigm, and Emperor. So this study showed that first, cardiovascular death or hospital admission for heart failure will be reduced for 62%. The cardiovascular death will be reduced half for 50% as well. So 68% will be reduced for hospital admission for heart failure, because we understand that most of people who admitted with heart failure, they admitted due to congestion, and all-cause mortality was reduced for 47%. It showed that comprehensive therapy is in favor in this category of patients. What it gives us? So if we will prescribe our patients 4 pillars, ARNI, beta blockers, MRI, and SGLT2 inhibitors, that will give us, if a patient, for example, 55-year-old patient with chronic heart failure with reduced ejection fraction, it will add 8 additional years free from cardiovascular death or heart failure hospitalization, as well as 6 additional years of overall survival. So I think it's very important message that we have. First, we have to think how to prevent congestion, and then, if of course it could be it happened, but when it happened, we have then to treat patients to relieve signs and symptoms of congestion. And in my conclusion, I would like just to remind you that patients with heart failure and clinical signs of congestion are at increased risk of diminished quality of life, hospitalization, and death. The administration of loop diuretics to achieve decongestion is the cornerstone of therapy for acute heart failure. Impaired diuretic response is a common complication in patients with acute heart failure and is associated with increased hospitalization and mortality compared with patients who have normal diuretic response. Of course, I have to just again to remind you that diuretics prevent congestion, but they have not been shown to prevent disease progression. Therefore, the use of neurohormonal antagonists, as I told before, 4 pillars prevent hospitalization, which usually are a consequence of the congested state and extend survival in patients with heart failure. Besides, ARNI, MRIs, and SGLT2 inhibitors may also possess diuretic properties. Thank you very much for your attention.
Thank you very much, Dr. Kisheva, for the very elegant presentation. I hope we will save a time for the future discussion. And now I would like to invite Dr. Marat Fudim. He will talk about splenic nerve modulation. Dr. Fudim, the screen is yours.
Спасибо за приглашение. Меня зовут Марат Фудим. Спасибо за приглашение, особенно доктор Марееву, доктор Солевова и Лопатину. Я перехожу на английский язык теперь. The topic is splentic nerve modulation, and it's a topic I've been dealing with for a while. There are some disclosures pertinent to this presentation, particularly I consult for a company called Axon. So we heard a lot about congestion, decongestion, and fluid removal particularly. I think the concept of fluid removal as a key therapeutic avenue to treat functional limitations of heart failure has been a little bit revisited in the last few decades. And this is a particular nice study to demonstrate is by Barry Borlaug. In patients with HFpEF, but the same is true for patients with HFrEF, is that most patients, 90% plus of our patients, are actually euvolemic in the free world. When they're at home, they are not congested, they're euvolemic, they're not short of breath. Yet, it is the minimal exercise that leads them to elevate the filling pressures. Remember, they don't have any extra volume, and they get congested. So it is the elevated pressures that lead them to stop exercising, not necessarily in excess of volume that we need to remove. So if you look at this in red, this is what happens to HFpEF and HFrEF patients when they simply elevate their legs. So for some reason, the passive translocation of blood from the legs into the chest, which is only 200 milliliters of blood, leads to an elevation of pressures by 7 millimeter Hg in average. This does not happen to the same degree in patients that are controls. Then when they exercise further, patients with HFpEF have this dramatic increase, HFpEF and HFrEF have a dramatic increase of intracardiac pressures. So the question comes, there's no additional volume added externally during this time point of exercise. Is there a redistribution of blood volume from the periphery? And we know there is, because that is also true for patients without heart failure. We all distribute blood volume centrally as part of a sympathetically driven recruitment with exercise. However, in patients that are predisposed, aka stiff hearts, same is true for the HFrEF and HFpEF, that blood volume translocation is not tolerated. So this is what happens in patients when we simply exercise, as little as walking down the street. We translocate blood volume from the so-called unstressed blood volume to the stressed blood volume. I can't go into the concept of the stressed and unstressed blood volume, but think of the stressed blood volume as the blood volume that is seen by the right ventricle as preload. So it's the preload determining volume that simply can be translocated from the periphery through vasoconstriction. And where is this vasoconstriction primarily occurring? Where it's actually primarily occurring in the abdominal compartment. The so-called splenic compartment is containing 25 to 35% of the total intravascular blood volume. It is rich in vasculature, and organs such as the liver and spleen are essentially sponges full of blood. And the venous system is primarily containing the majority of that blood volume and is highly innervated with autonomic nerve fibers. The autonomic innervation of the gut is 20 times higher than the autonomic innervation of arms and legs. So for some reason, whatever you believe in, God or nature, they placed a lot of autonomic fibers on the venous structures in the abdomen because that's where the fluid is going in and out. The nerves, the autonomic nerves that control the abdominal compartment are the so-called splenic nerves. There are 3 nerves on each side that confluence in what we call the celiac plexus. It sits on top of the aorta. So what happens when we stimulate those nerves? What can we reproduce the shift of blood volume from the abdomen to the chest? And it appears that we can. This is what happens when we exercise. There's an acute rise in preload, central venous pressure, and near 50% increase, and near doubling of arterial blood pressure and of cardiac output. This is what we see in healthy dogs, and it's reproducible. You stimulate for 10, 20 seconds, and pressures go up, pressures go down within a few minutes. We can reproduce this for weeks and months at a time. Now in humans, these are healthy adults where we stimulated those nerves directly. We again were able to double the arterial blood pressure, double the cardiac output, and increase the central venous pressure by 50%, all in the duration of the stimulation. And then after the stimulation is over, 30-second stimulation, the pressures are falling, and within a few minutes, you reach baseline. So we said, well, This is all nice and well in healthy adults and in healthy animals, but what if we do that in diseased humans, in patients that have heart failure? So this is a study in a single patient, actually, where we used a transvenous approach. So we placed the catheter down into the azygous vein, into the intercostal vein, because that's where the splenic nerve intersects the vein on a regular basis. So the stimulation, again, was occurring for 20 to 30 seconds. And what we saw, as in previous healthy controls, is that so it was a 50% increase in pressures within seconds. But look what happened here and compared to our controls. The pressures actually never returned back to baseline, but actually continued to climb. So this really indicates that a diseased ventricle, the translocation of blood centrally from the abdomen results in a further decompensation. I think of it like a spiral. It's a vicious cycle where you shift blood centrally and now the heart continues to decompensate. So this is probably how cardiac decompensation can happen in somebody who's euvolemic. This patient's left atrial pressure at baseline was 8, and we brought it up all the way to 16, 17, and then it continued to go up to 20. So if we can shift blood centrally and that causes cardiac decompensation, maybe in return we can block this process or prevent the distribution of blood to begin with. So we have done that in a series of studies. The first study was the so-called Splenic Hf Study. You know, too bad that Splenic is such a complicated word. Otherwise, I would have chosen an easier study title. But the acute blockade of the nerve in patients with acute decompensated heart failure led to an acute reduction of intracardiac pressures with a peak effect around 30 minutes. That was true for the right-sided pressures, left-sided pressures. That was also true for the arterial pressure. This was a bilateral block, a quite powerful way to reduce intracardiac pressures by shifting blood back into the abdomen. In parallel, we saw an increase in the cardiac index, all temporary. So then we said, well, listen, it's good we did that in a resting condition. Can we now replicate that in patients during exercise? You remember Barry Borlaug's curve? That is the top curve. This is now HFrEF patients. Legs up, pressure goes up. With exercise, it continues to go up on the right and on the left side. What happened when we blocked those nerves and repeated the exercise 1 hour later in the same patient? We saw an average reduction in resting and exercise-induced pressures that was actually relatively dramatic. We're talking 5 to 7 millimeter HD on both sides. This then translated itself to an increased workload, a trend towards higher peak VO2, and a higher 6-minute walk performance. All of this was probably driven by arterial and venodilation. Now, I can tell you that I cannot measure venodilation because this is actually not easy to do, but I can measure arterial dilation. So we saw the reduction in central arterial vascular tone. We saw also a reduction in central vascular volume translocation. So we measure how much water was on the lungs using bioimpedance, and compared to pre, this is one case example that was particularly illustrative, but compared to pre, there was no translocation of blood volume into the chest. A positive signal is translocation to the chest. In average, across the patient sample of 15, there was a 30% reduction of central blood volume translocation. We then modeled how much actually did we reduce that stress blood volume. So that's the translocated blood volume. And that averaged by about 500, 600 milliliters, but that was already present at a resting state. So you see the curves mimic very much closely what you just saw with the pressure curves. There was a resting reduction in stress blood volume, and with the exercise, there was no additional added stress blood volume that was explained by the splenic nerve blockade. So it's really, all the benefit was already occurring actually at rest. So then Peter Panikowski and colleagues in Poland and in the Czech Republic actually did the same experiment, but now surgically resected the nerve. I did not have the permission to go ahead and do that right away at my institution. I probably would have been fired for this, but they were able to do this, and they actually surgically resected one side. And what they found is that, very similar to the curves I just showed you, they were able to reduce resting and exercise-related pressures, not just at the 1 day mark like me. They went all the way out to 12 months. They actually did repeated tests at 1, 3, 6, and 12 months, and we're seeing very, very similar magnitude of results in those 11 patients. It was actually 11 patients enrolled total in that study. One dropped out early. So they also saw an improvement in NYHA class scale. They saw a significant improvement in quality of life and a duration and exercise performance similar to what I've seen in my study. So since then, we have completed 2 more studies, and one of them I'm showing you is the study in HF patients using catheter-based approach. The same catheter went to stimulate. That catheter in the same position can now denervate the splenic nerve, and we have studied 11 patients with HF. There were procedure-related complications, but they were all really anesthesia-related, not related to the procedure itself or the absence of the splenic nerve. There was no orthostasis, there was no nausea or vomiting, with the exception of one patient that had limited mild diarrhea. What did we see? This is an open-label, single-arm, uncontrolled study. We saw a 6-minute walk test improvement all the way out to 12 months with continued progression in symptoms. As is shown here on the right, quite dramatic improvement in KCCQ by 40 points. And then we saw a reduction in NT-proBNP, which was really steady throughout the study, as you can see here on the slide. Last but not least, so in summary, splenic nerve plays obviously an important role in acute and chronic decompensation. It's important I show you data for primarily exercise studies. It's important to acknowledge that probably splenic nerve vasoconstriction also plays a role in just obviously congested patients that are hospitalized and have a lot of fluid on board. A lot of that fluid probably could be stored away in the splenic compartment, but it's not due to sympathetic hyperactivation. So we propose splenic nerve ablation as a promising new therapeutic approach, not only for ambulatory, but probably also for acute heart failure patient. Currently, there's a trial ongoing called the Rebalance HF trial. It's a randomized sham controlled study where we do exercise, ablation, and repeat exercise at 1 month with follow-up all the way out to 12 months. And I hope to present you results late next year. Thank you very much.
Thank you very much, Dr. Fudim. Our congratulations, fantastic report, many thanks. Now we have time for the discussion. We have several questions in the chat, and I kindly asking Yura to continue to lead this part of the session. Please, Yura.
Thank you very much. So let's discuss some questions. There was a question in the chat. First question for Per Paolo. So, for example, imagine 2 situations. First, patient came without new symptoms, without clinical congestion, but with some congestion by ultrasound. Should we increase dose of diuretics or maybe change optimum medical therapy? And the opposite. Patient came to us with additional dyspnea. So dyspnea increase. There were no clinical increase in congestion, and there were no increase in congestion by ultrasound. What should we do?
Yeah, thank you very much. I think you need always to optimize treatment for which there is evidence that you are going to prolong life. But the problem is that when you have patients with severe congestion by ultrasound, these people do not only have severe congestion, they're usually elderly, they have low blood pressure, they have a kidney that doesn't work. And actually it's very difficult then to optimize guideline indicated treatment that might help them improving survival or keeping them outside from hospital. So the only way is to adjust the diuretics, and these markers of congestion are associated with higher doses of diuretics. And then when you fail to adjust diuretics, then you need to ask Frederick and say, Frederick, what do I need to add more? Because you need to unlock the kidneys then to trying to keep them outside from hospital and avoid an early death, I think, although. Yeah, so I hope I answered your question, although I'm not convinced.
Okay, thanks. This is the first part of the question. And the opposite, patient have increased dyspnea, but not clinical congestion, not congestion by ultrasound. What should we do?
Yeah, as we said before, signs and symptoms are very subjective. So it's not something that I really trust all the time. So you need to investigate whether this is true or not. We have many tools that can identify, we have many diagnostic tools that tell the truth. One that I really like is NT-proBNP. Many might say, in obese individuals, it might work less, but if NT-proBNP is low and there is no markers of congestion, I think you can be reassured, then your patient can be reassured that then shortness of breath is probably not cardiac, but take everything into the consideration. So the clinical examination, as Angela said, and the BNP and the ultrasound all will indicate where you should then go with your treatments.
Okay, thank you.
Okay, can I briefly comment?
Yes.
Yeah, so on the first point of the patient coming in, where you have kind of the dilemma between should I optimize the treatment or the disease modifying treatment or go for diuretics, I think that my take on it is that when it's a real difficult patient, sometimes it's better to admit him for 2 or 3 days and really try to get the hemodynamics right. And then maybe even what I sometimes do is even remove or decrease the beta blocker or the Entresto for 1 or 2 days, get them in optimal fluid status, then come down on the diuretic, even stop the diuretic in hospital, and then try to up titrate everything and optimize everything. And if you do this in hospital, you have much more control. And I agree completely with Pier Paolo. Getting patients on the optimal doses is best. Sometimes it's difficult to do outpatient. That was one message. And then the second one on the patient complaining more from dyspnea, but without clear clinical evidence of congestion. So our approach there is that we have started kind of a dyspnea clinic where the basic examination is basically exercise echo with CPAT. So many patients, they complain of dyspnea, but they complain of dyspnea at exercise. And of course, when you want to assess that and when you want to employ all the nice tools that Pier Paolo has taught us, it's sometimes important to employ them when the patient exercises, because that gives us a total different information, and that also comes down on what Marat has taught us. We evaluate mostly our patient at rest, and we should probably do it more at exercise, and that gives us very important information.
Thank you. Yes.
Maybe just a question about urinary sodium. We had a question from audience, and it's very interesting. But in Russian routine clinical practice, it is very difficult to use like 2-6 hours algorithm, because if patient is not in ICU, it's more feasible to estimate urine sample during morning. Can you tell us your thoughts about the value, clinical and prognostic, of the morning sample of urine, so in terms of measurements of urine sodium there, and also the value of urine sodium in outpatient setting?
Mm-hmm. Yeah, these are excellent questions. So I don't think, first of all, that the 2-hour time, like it's put in the guideline, this is a make or break deal. I think it's probably when you take it after 1 hour, if the patient starts peeing in response to his diuretic, and you take it at 1 hour, it probably works well as well. So the way that I tend to do it, to use it practically in the hospital, is it comes down on training your nurses. They are very used when they give something for blood pressure that might lower blood pressure. They will look at the blood pressure first, and if it's really low, they will not give the beta blocker or whatever that is decreasing. You have to teach them they should do the same for IV diuretics. And so the way that I often do it is I have learned the nurses, when IV diuretics are prescribed, usually it's at 8 o'clock in the morning, that they are just trained to do a spot sampling after their rounding for the medications at 8 o'clock. They would just collect the samples for the patients on IV diuretics. And then when the doctors round, which is then a little bit later, they will have the results of the urinary sodium, and they will determine the diuretic treatment up till the next morning. So in this way, it works very practically. So they just do it after their morning administration, and then the doctors will determine the diuretic treatment based on this for the next day. And then your question for in the outpatient clinic. So Of course, the difficult one there is that when you want to employ the urinary sodium as in the algorithm in the guideline, it's important that you have urine which is produced by the diuretic. So your patient theoretically should void empty, then you should administer the diuretic, and then you should measure. So this is quite hard to organize in the outpatient clinic. You should realize that when you take your urine sample before your diuretic administration, it's probably going to be quite low. And we know that the morning samples, for instance, when it is really low, it might predict occurrence of diuretic resistance, and you might even see that for a patient who has a rather stable urinary sodium and it suddenly drops for some reason, that this patient is at risk to be readmitted. That was a paper from my colleague Peter Martens in JACC heart failure.
Thank you very much.
Can I add a little bit, Chester, for the question? I can understand that, for example, in maybe in Russia, or according to your question, it's I guess it's very crucial that was mentioned that it's very important to see the urine sodium before starting the treatment, and then, because in our settings it's not so easily to assess their urine sodium after administration of loop diuretics, especially outpatient clinics, and we have to be very clear. And and we have to understand that the correlation, maybe it's, well, the guidelines is a very crucial statement, but we also have to understand that we have to adapt them to our reality. So probably if it's not so easily to assess the urine sodium, we also can look for urine output, right? So we can assess if it's effective or not. I mean, our decongestion strategy. According to the first question about dyspnea, I would just like to add something, because the dyspnea is a broad symptoms for different kind of a disease, and we definitely have to make a differentiation of this disease. First, we have to see for coronary artery disease as well. So that's very important about the exercise testing, and I guess that will make some kind of a sense that one test will not show that the patient is in congestion or it's not in congestion, as well as the X-ray, for example. The X-ray can be very, normal. I can't say totally normal, but it can be not so bad. It cannot show the overload, but at the time the patient will be overloaded. So we have to be very careful and not to look just for one criteria or one symptoms or sign. Thank you.
Thank you.
Marat, maybe a question for you, because I always think how we can measure this volume redistribution, how we can presume that this patient probably has this. And we see in your recently published paper on the IVC sensor, and my question is probably your ideas. Could it be the marker or sensor for volume redistribution, and in which patient particularly we can apply this technique? Because, for example, we know that in chronic heart failure patients, IVC diameter can be very high, and probably the wall parameters like maybe stiffness of the vein will be developed. So what are your thoughts on this?
Thanks for the question. So first of all, that paper on the IVC filter, actually Tastani led all that work. I was just, had the chance to contribute to this. So I think what you are getting down to is, how do we know if the patient's congestion status is driven by volume overload or purely by redistribution? So it's vascularly driven. And I think that we need to be very, very clear that the majority of our patients are euvolemic. And actually, if you measure their blood volume, which would be the gold standard, you would see that many patients in the ambulatory setting are euvolemic. There are some that are hypervolemic. So those who probably want to diurese more. But in most cases, it's true that the vascular tone is elevated. And I think that's where GDMT comes in. And, the majority of them really work through a reduction of vascular tone. In the perfect case scenario, we would have a test that tells us whether a patient is volume overloaded or on the vascular constriction spectrum. I don't think we have that test. We can approximate it by measuring blood volume, by stress testing people. So for example, if you take somebody on the table and they have normal right filling pressures and the IVC is collapsed, and only with exercise, the IVC dilates and the pressures goes up. Well, that's a redistribution phenomenon in stiff hearts. You cannot diurese that off. In reverse, if you get somebody on the table and the right atrial pressure is already 15 and the pressures are already, and the IVC is dilated, clearly this is somebody on the far right spectrum with volume overload, but you cannot exclude that the vascular tone is already high. So in the absence of us being able to measure compliance, which I call the holy grail, we cannot measure compliance of the venous system. That tends to be the biggest problem. And I think that's where this IVC filter actually comes, IVC sensor comes in, because it allows longitudinally to trend in patients to test compliance. Because I think that it tends to be more sensitive to vascular, to volume changes than pressures. That's essentially what we're showing in the paper. It's a more sensitive marker, and I think it's because it's more a reflection of that than it's pressures. So I'm going to repeat that. Pressures are a terrible surrogate of vascular compliance, but the IVC diameter might be a much better compliance. So Pierpaolo probably gets a lot more out of it by looking at the collapsibility than you would by looking at RA pressure only. But there's no perfect measure.
Thank you. Unfortunately, now it's time to close this very interesting session. And first of all, I would like to thank all the speakers for the brilliant presentation. As a member of the board member of the Russian Society of Pathology and Russian Society of Pathology, I would say it would be helpful, it would be interesting to repeat this session in the future. I hope you will do that, Yuri.
Yes, thank you for your help and help everybody. There was a great talk. I think congestion is very important, and the new definition of heart failure, additional time, show how important to measure congestion. Thanks for our audience. They give a lot of good questions. Unfortunately, we can't answer all of them because we have lack of time. So thanks everybody. I think we should finish the session, and it was really great to speak with all of you.
Bye-bye.
Bye-bye.
Bye. Thank you so much.
Bye-bye.
Bye, everybody.
Лечение сердечной недостаточности требует обширных знаний и высокой квалификации врача. Жизнь с сердечной недостаточностью также предъявляет серьезные требования к пациентам и их родственникам. Сложно разобраться в большом количестве препаратов, сложно следить за симптомами и правильно оценить их опасность. Наконец, сложно не сдаваться и не терять надежду. Помогите своим пациентам найти информационную поддержку и ответы на вопросы, которые у них возникают каждый день. Русскоязычная версия сайта Европейской ассоциации по сердечной недостаточности создана при участии Общества специалистов по сердечной недостаточности. На страницах сайта пациенты и их близкие найдут ответы на самые разные вопросы. Причины и симптомы сердечной недостаточности. Как сердце и организм пытаются перестроить свою работу для адаптации к сердечной недостаточности. Чего ждать от вашего врача? Все о медикаментозной терапии сердечной недостаточности. И какие вопросы нужно не забыть задать на приеме у врача. Вам рекомендовано имплантировать устройство для контроля сердечного ритма. Что это значит и как изменится ваша жизнь? Что может сделать сам пациент, чтобы держать заболевание под контролем? Как самостоятельно измерить артериальное давление и частоту сердцебиения? И почему необходимо это делать регулярно? Питание, физическая активность, режим отдыха, другие аспекты образа жизни пациентов с сердечной недостаточностью. Эмоциональные проблемы и психологическая поддержка. Информация для членов семьи. Простые способы оказания помощи члену семьи, страдающему сердечной недостаточностью. Опасные симптомы, такие как боль в груди, одышка, нарастание отеков. Кроме того, на сайте представлена серия простых и увлекательных анимационных видео, объясняющих сердечную недостаточность и ее лечение, полезные материалы, которые можно распечатать с сайта, а также много другой полезной информации, которая поможет вашему пациенту лучше разбираться в своем состоянии и следовать вашим рекомендациям. Лечение сердечной недостаточности требует обширных знаний и высокой квалификации врача. Жизнь с сердечной недостаточностью также предъявляет серьезные требования к пациентам и их родственникам. Сложно разобраться в большом количестве препаратов, сложно следить за симптомами и правильно оценить их опасность. Наконец, сложно не сдаваться и не терять надежду. Помогите своим пациентам найти информационную поддержку и ответы на вопросы, которые у них возникают каждый день. Русскоязычная версия сайта Европейской ассоциации по сердечной недостаточности создана при участии Общества специалистов по сердечной недостаточности. На страницах сайта пациенты и их близкие найдут ответы на самые разные вопросы. Причины и симптомы сердечной недостаточности. Как сердце и организм пытаются перестроить свою работу для адаптации к сердечной недостаточности. Чего ждать от вашего врача? Все о медикаментозной терапии сердечной недостаточности. И какие вопросы нужно не забыть задать на приеме у врача. Вам рекомендовано имплантировать устройство для контроля сердечного ритма. Что это значит и как изменится ваша жизнь? Что может сделать сам пациент, чтобы держать заболевание под контролем? Как самостоятельно измерить артериальное давление и частоту сердцебиения? И почему необходимо это делать регулярно? Питание, физическая активность, режим отдыха, другие аспекты образа жизни пациентов с сердечной недостаточностью. Эмоциональные проблемы и психологическая поддержка. Информация для членов семьи. Простые способы оказания помощи члену семьи, страдающему сердечной недостаточностью. Опасные симптомы, такие как боль в груди, одышка, нарастание отеков. Кроме того, на сайте представлена серия простых и увлекательных анимационных видео, объясняющих сердечную недостаточность и ее лечение, полезные материалы, которые можно распечатать с сайта, а также много другой полезной информации, которая поможет вашему пациенту лучше разбираться в своем состоянии и следовать вашим рекомендациям. Лечение сердечной недостаточности требует обширных знаний и высокой квалификации врача. Жизнь с сердечной недостаточностью также предъявляет серьезные требования к пациентам и их родственникам. Сложно разобраться в большом количестве препаратов, сложно следить за симптомами и правильно оценить их опасность. Наконец, сложно не сдаваться и не терять надежду. Помогите своим пациентам найти информационную поддержку и ответы на вопросы, которые у них возникают каждый день. Русскоязычная версия сайта Европейской ассоциации по сердечной недостаточности создана при участии Общества специалистов по сердечной недостаточности. На страницах сайта пациенты и их близкие найдут ответы на самые разные вопросы. Причины и симптомы сердечной недостаточности. Как сердце и организм пытаются перестроить свою работу для адаптации к сердечной недостаточности. Чего ждать от вашего врача? Все о медикаментозной терапии сердечной недостаточности. И какие вопросы нужно не забыть задать на приеме у врача. Вам рекомендовано имплантировать устройство для контроля сердечного ритма. Что это значит и как изменится ваша жизнь? Что может сделать сам пациент, чтобы держать заболевание под контролем? Как самостоятельно измерить артериальное давление и частоту сердцебиения? И почему необходимо это делать регулярно? Питание, физическая активность, режим отдыха, другие аспекты образа жизни пациентов с сердечной недостаточностью. Эмоциональные проблемы и психологическая поддержка. Информация для членов семьи. Простые способы оказания помощи члену семьи, страдающему сердечной недостаточностью. Опасные симптомы, такие как боль в груди, одышка, нарастание отеков. Кроме того, на сайте представлена серия простых и увлекательных анимационных видео, объясняющих сердечную недостаточность и ее лечение, полезные материалы, которые можно распечатать с сайта, а также много другой полезной информации, которая поможет вашему пациенту лучше разбираться в своем состоянии и следовать вашим рекомендациям. Лечение сердечной недостаточности требует обширных знаний и высокой квалификации врача. Жизнь с сердечной недостаточностью также предъявляет серьезные требования к пациентам и их родственникам. Сложно разобраться в большом количестве препаратов, сложно следить за симптомами и правильно оценить их опасность. Наконец, сложно не сдаваться и не терять